Afternoon. I think we're going to start. This is our last child psychiatric grant rounds. I mean, there are still general psychiatric grant rounds this month. Last, but maybe one of the most important, Dr. Afsari, he will be talking about relationship between childhood trauma and adult health. He's going to review one main study and then also discuss some other studies along with that. He has nothing to disclose. Just I'm going to give you a brief introduction because he has a lot of material to present today. He said he's going to take the whole hour. Dr. Afsari, he's a second-year child psychiatry fellow. He's finishing at the end of June. He has been chief fellow this year too, which takes a lot of effort and courage on the part of trainees, right? Courage, okay. But he has to juggle, all the training responsibility, his training, other people's training, and also he has, young kids. And as far as his background, he did his Doctor of Osteopathic Medicine from Toro University College of Osteopathic Medicine in California. And then he came to our program in general psychiatry. He did his general psychiatry residency. Then he joined the child psychiatry. And I think he is planning to stay in Tucson. That will be good for us and the community. And the other thing I was going to say, he recently published a book review in Orange Journal, which was last month. So if you want to look at it, it was a nice job he did. Okay, well, thank you.
All right, thank you for that introduction, Dr. Guman. Can you guys hear me okay? Okay, good. When I took public speaking in high school, the one thing the teacher told me was talk slower than you think you're talking because you're going to rush, right? That's what they tell you. So I told my supervisor I'm going to do my grand rounds on early trauma affecting people throughout their lifespan. And his one piece of advice was, well, you better talk fast. So I'm kind of torn between talking slow and talking fast. But if I do rush, I want you guys to stop me because there is a lot of information. But please, if something's not making sense, go ahead and stop me. Because it makes no sense to keep going if things are confusing. So today I hope to touch on some important ideas about trauma. It's just the tip of the iceberg. We're only going to get so far today, but it can hopefully stimulate some of your thoughts, not only with your patients, but with people in general. So why study the effects of trauma? I mean, it's a big deal throughout the nation, throughout the country, obviously. Abuse, neglect, and various forms of trauma do affect people. We know that. For me personally, it helps me integrate concepts of development, behavior, and pathology. It also gives me some clues to the underlying factors of certain disease states. When I'm talking to a kid who has a traumatic past, it's really important to get into that to see how it might be affecting them as well as adults. And I think as clinicians and researchers, we often have this intuitive sense something bad happened to this person. And I think we're very curious about that. So what made this person kind of get into these behaviors or get into these problems? And I think, intuitively, we know there's a problem. And so simply put, we kind of want to know how this cute baby, turns to this adult, and that happens, right? And how these children, they look happy, they end up, criminals or something. That's in a big sense. Obviously, this is very kind of big picture type questions. And what happened and what can we do about it? So the next slide will give us all the answers and we can go home, right? Not really. So it's really complicated. There's biological factors, there's genetic factors, individual temperament, coping, obviously parenting styles and attachment patterns, and also childhood environment, including maltreatment. So this last part's what we're going to be focusing on today. And I'll also be touching on some of the other stuff up top, but trying to tie it in together. I'm really focusing more on the childhood maltreatment part. So there have been numerous studies that have explored early trauma and its influence on mental and physical health. Many were narrowly focused or too small to quantify the effects of the negative behaviors. So for instance, you had a study that focused on childhood sexual abuse and its ramifications later on in life. But obviously in that family there's likely going to be other areas of problems. And so it's really hard to quantify these problems just generally in a research paradigm. So what conceptualization of what is trauma, not only abuse and but other forms of kind of soft science, health, education history, addiction history, and there was a study done. That's what I'll be talking about. It's called the ACE study. It's over a decade-long study. It was carried out by the CDC and with collaboration with an HMO in California, Kaiser Permanente. You guys might have heard of Kaiser. It's a large study. 17,000 people participated. And the participants were kind of predominantly middle class. They all had insurance, average age of 57. So just to give you a sense of that number, that's 10 times the number of the previous largest study done. So the largest study done prior to this was in the more like 1,000 range. This one was 17,000. So first off, a little more about who was followed. So these people are actually 80% white. Childhood experiences. And I actually have a handout there. One of them is a survey of these adverse experiences and kind of goes through it. So there was a lot of data gathered by this. Not only were these people given these questionnaires, they were also given a comprehensive physical exam right after they were given the questionnaire, and there was also a lot of medical documentation to back up some of their kind of findings. And since that time, there's been 25 peer-reviewed articles based on this initial study. I do have another list, which is a reference list that I've gathered much of the information from. So if you have any questions about, where are these numbers coming from and, how did they find these studies or how did they find these results, et cetera, there are quite a bit of information out there now studying various aspects of how these people who answered these questions, how they ended up with these results. So I do I suggest you kind of look that up if you're interested in more information. And also, just to let you know, I did gather much of my information for this presentation as well as the charts and graphs from these various studies. Any questions so far? Everybody with me? Okay, yeah. So the principal investigators, they had, again, there's a CDC with the Kaiser HMO group. They had a few key hypotheses of the study. One was that childhood traumas lead to a wide array of negative health and social consequences. And two, the stressful or traumatic experiences negatively affect childhood development. I think that's a big key. So a lot of times when we're looking at childhood trauma, it's sort of, okay, so this happened, this bad thing happened, and then they ended up using drugs. But not really talking about the concepts behind it or maybe going into why this is happening. And so their hypothesis was that there's negative childhood development. It affects kids and teens and young adults negatively, and it sets the stage for the later problems. And the goal was to quantify these effects in a way that hadn't been done before. So again, using 17,000 people, they thought maybe they had a good shot of getting some more clear information. So we talked about the hypothesis. Now the conceptual framework, the following is a pyramid that they used in the CDC website. It's there as well. And they tried to explain how these adverse experiences may lead to disease and social problems. I'll be coming back to the pyramid every now and again. But if you look here, there's these adverse experiences, and they're saying, the theory is they're going to lead to some sort of impairment, developmental delay, etc. And that leads to adoption of risk behavior and then disease and early death. And I just have a couple thoughts about the pyramid. I don't know if you guys have some thoughts, but this is kind of clear, like yellow and up. I think part of our medical model really focuses on maybe trying to help people stop these as far as smoking or getting more active or not using drugs. And so primary prevention really is focused here. And not surprisingly, a lot of our money and time and energy resources are kind of focused here. I think the researchers were kind of trying to imply that maybe this is a little too it's too little and too late possibly, and that really there's much larger things going on leading to these huge problems we have in our society. And I think that they did a pretty bold thing by really putting this there. I mean, this is a very vague, kind of nebulous area that is obviously kind of hard to study and quantify. As child psychiatrists, we deal with it every day. And I think as psychiatrists in general and clinicians and psychologists, we also deal with it. But is it really talked about a lot? When you talk about public health measures and primary prevention, do we really kind of focus on maybe this part of it? So that's just a couple of my thoughts. We'll be coming back to the pyramid a few times. But I want to get into the nuts and bolts of the study. So what are they, these adverse childhood experiences they looked at? So really they fall in three domains. Again, I handed out the questionnaire, the survey. The three domains are abuse, so there's three questions really about abuse. There's neglect. And that's been commonly studied. A lot of people have done stuff like that, again, in smaller ways and different ways. But then, they really kind of incorporated these things that are sometimes difficult to quantify. And again, these are self-reports, so they're not going to be entirely accurate. But the goal was to get some information from these people about what was it like living at home? Did your parents fight a lot? Were they separated or divorced? Did one or both parents use drugs or alcohol? Were one of your parents in jail or prison? Was one of them depressed, or did they try to commit suicide or other types of mental illnesses? And they also talked about chronic illness. So they asked a lot of questions, and from these, they actually, it's not perfect, but they got a score. So everybody got a score. If you answered questions, this one, let's say, and these two, then you got a 3. If you had none of these, your ACE score, they call it, you got a 0. You had all of them, you get a 10, right? So that's how they're doing it. And again, the model might not be perfect, but I think it was a pretty, interesting way of going about doing it. You're kind of limited in this type of study anyway, and so they figured, why not give it a shot and see what they get? Here's a sample excerpt from a study questionnaire. The full thing is I handed it out, but I just wanted to put a sample there just in case I wasn't able to get a hold of it. So they found a few things. One, that these ACE, adverse childhood experiences, are common. Then if you look at the most common ones, substance abuse in the household was 27%, physical abuse 28%, sexual abuse 21%. These numbers are actually quite in line with a lot of other studies they did prior. So they're not shocking to anybody. But they did, they do seem to me to be quite common. I was kind of surprised about sexual abuse, to be honest with you. It was like a really high number to me. And one of the things that I thought about was the demographic was middle class. They had insurance. Half of them went to college. That's kind of surprising, actually. I was surprised by that number. And I guess substance abuse 27%. I shouldn't be surprised, and maybe I still was. And you would imagine, one kind of can think maybe it's even low on the low end given the sociodemographics. So it's potentially maybe even higher. what they did was they kind of figured out, okay, how many people had a score of 0? So a third. A third grew up without any of these things. It's actually pretty good. And then 2/3 had at least one. And if you look here, 1, 2, 3, 4 more. 4 more is quite high, actually, 17%. 1 out of 6 people surveyed had 4 more of these adverse experiences. I thought that was pretty surprising to me. I don't know what you guys think, but maybe you can share that with me or later. Again, the key findings. So they're common. They're common. They tend to occur in clusters rather than occurring on their own. So if you answered 1, yes to one of them, you had 3/4 of a chance that you had another one. Okay? And then there was a strong and graded relationship to numerous health, social, and behavioral problems. That's what their kind of findings were. And that's what we're going to get into a little bit. So let's go into this. We're not going to get too much in depth into this green section. This is the trickiest one, but we'll talk a little bit about it. So what they did find was this, there was a strong relationship between ACE score and some psychiatric disorders. Some of it quite surprising. Depression throughout the life, about 50% said that they had experienced a depressive episode with a score of 4. And about, I think it's 13 or 14 was with 0. And if you look at it, the interesting thing is, look at that. It's almost linear, which is pretty neat. I don't know. I mean, it kind of says maybe there's something here. And then with the suicide rate, this was kind of interesting. It was fairly low, obviously. Almost 20% had attempted suicide with a score of 4 or more, 20%. And a little bit more on that. There was actually a JAMA article that really talked about that, 2001. And if you look here, 0 is the baseline. Go down the list. A score of 7, 31 times more likely to attempt suicide. I don't know what you guys think. I think that's pretty surprising. And it's a pretty, linear increase. It gets really exponential over here. It's kind of helped me a little bit when I'm dealing with certain situations, either in the emergency room or otherwise. I'm always concerned, but I see somebody like that, and I'm really kind of, not panicked, but I'm really worried. Something might, they might try to do something if they're telling me they're thinking about it. So I think that this is a really important slide to look at, generally. And it's also important to really kind of look at the trauma history when you are assessing people who may have thoughts of self-harm. I think that's really important. Just in general, but then given information like this, maybe we should look at it a little closer. Yes? Attempt. Right. Any other questions so far? Okay. A brief summary about this. We're going to get more into this. This is tricky. I have to say, this part is tricky. But, they likely disrupt some neurological emotional development, trauma in general. And the thoughts from the authors were, by adolescence, children do have sufficient motivation and independence to seek some release of these negative emotional states through the following. Not only negative emotional states, I should have changed that. Maybe disrupted neurodevelopment would be better. I think that's my thought, is they're also feeling there's these negative emotional states, and I can talk about that a little more. But so then you go into this one that we really kind of focus on: primary prevention, adoption of health risk behaviors. Obviously, this is very important because it leads to this stuff, and also it really decreases quality of life. So the adoption of health risk behaviors, we know a few things. Most of these behaviors start in adolescence. They include alcohol abuse, sexual promiscuity, using psychoactive materials, including tobacco and illicit drug use, overeating, delinquent behaviors. Right down the line, I think it's been shown that most of these patterns or habits really start in teenage years and young adulthood. And so it's kind of important to look at these kids. Maybe there is a, what's going on beforehand that's affecting them to do that. They looked at the relationship between the adverse experiences and STDs, so about 2.5 times more with an ACE of 4. This is similar to the HIV graph. HIV positive graph is similar to this finding. And it makes sense, right? And I don't know what that did. Something is not working. Please bear with me. Is there anybody from the tech support? Let me just see if I can get it running. Okay, we're back, I think. Okay, so we're talking about the STDs. There is an increase quite a bit. If you look at, this is really, I thought, interesting. Males with an ACE score of 6 are 46 times more likely to become IV drug users. And they suggested about 3/4 of female IV drug users can be attributed to these negative experiences. Again, the author that published the suicide article from JAMA did this study as well. So ever-injected drugs, fairly low, about 0.2% at baseline, increasing to more than 1% with the 2 adverse effects. And then really, even though that doesn't seem like a huge number, 4%, it's really big. It's 40 some odd times bigger than if you had none. Current smoking as an adult also showed an increase. Self-reported alcoholism. This likely is underreported, so it's likely that these numbers are higher, just generally we found with alcohol. But there is a pretty big increase, over 15% and more about in the 2 to 3% with 0. So a little bit of a summary on these high-risk behaviors. Again, this is kind of my thought here. They're likely driven to some extent by underlying trauma, which leads to depression, anxiety, shame, guilt, and feelings of worthlessness. That's my kind of, I don't know, thoughts on it, as well as disrupted neurodevelopment. They do usually start in adolescence and young adulthood. So these two things here are a little controversial, but I think it's important to mention. So we can look at addiction in several ways. I mean, maladaptive coping styles, patterns of behavior that are irrational, whatnot. But if you look at it in this light, it may be viewed at least partly as a personal solution to overwhelming negative emotional states. I see a lot of blank stares. I don't know. I mean, that's a little bit, I think it's fair to say that that's possible. And viewed in this way, what appears to be reckless and irrational behaviors may have an underlying purpose. So trying to get rid of these feelings that are maybe garnered from these horrible experiences that they had in childhood, in their family, etc. So it kind of makes sense. Maybe by teenage years you say, well, I just want to feel better. That's a personal solution. And these are overwhelming kind of feelings that they can't control. So what if, my thought is, we really target on stop the drug use, stop drinking, stop that. Those are all good. And then I think as psychiatrists we work on the trauma too. And child psychiatrists were very interested on that, what happened when they were growing up. And I mention that because it doesn't seem obvious at first, but society and public health, it does seem to be very focused on the behavior and maybe not on some of these more kind of complicated, vague, nebulous reasons. So we go into this pyramid again, right up to the disease part. Again, a lot of our money and time and effort. Look at the medicine wards here. Go down, the ICU and primary care. And I mean, we spend most of our money actually here. And it's not just because of trauma or just because of bad behaviors, but a lot of it is. And the studies that they found, there was a strong relationship with these ACEs and things like heart disease, fractures, obesity, obviously alcoholism, chemical dependency, incarceration. I thought this was pretty straightforward. It makes sense that people who drink more are going to have hepatitis and jaundice. I thought this one kind of made sense. ACE score and COPD was going to be on the rise, right? This one was pretty interesting and published in Circulation by internal medicine doctors. 20% increase for heart disease if you have a history of smoking. This is corrected risk factors. 40% for domestic violence, 50% for childhood physical abuse, about twice as much for hypertension. Complex child abuse, multiple abuse with neglect, 3 times higher. Now, you might not want to believe it, and that's fine. That's okay. So I would say look it up. I mean, maybe there is some problems with some of the statistics, or maybe they didn't do it fully, or maybe there's other factors, or something's going on. But something is going on, and that's, I think, why I found this study so interesting, because it helps. I mean, I think it shifts our way of thinking a little bit. It's not just these biological factors. There's also complex biological mechanisms at play when people are exposed to these multiple type of traumas, stress, neglect, and I'll be talking about that a little bit. I'm actually doing pretty well on time, so I'm not going to rush that much. Disease, disability, ACEs are major. This is what the study authors kind of concluded, and I think this is fair. Major hidden engine underlying preventable risk factors for various chronic diseases. They increase the likelihood of early smoking initiation. A graph I didn't show you was early smoking by 14 was very similar to the COPD graph. Chronic obstructive pulmonary disease. They do bear a strong relation to depression, which is leading cause of disability in the world. And they may play as strong a role in chronic medical disease and disabilities other more commonly studied culprits. Again, I'm saying that. It's a big thing. And I think it's one of those things that, in general, our medical model is kind of not equipped to deal with yet. But I think the picture is showing that they are very, very important factors in chronic illness and also with disease, psychopathology throughout the life. So we really focus a lot on obesity, physical activity, cholesterol, smoking. But then do we really focus a lot on what happens with kids, young kids in their homes, broken families? We do, but enough is enough. I mean, do we do enough, I guess, is the question. And maybe we're not doing enough. Early death. So makes sense. You're going to have all these problems. There is a correlation with adverse experiences and early death. This was recently published, 2009. It's on the reference. It's shown that there is a statistically significant relationship. Average age of death is about 79 with an ACE of 0. And they found with an ACE of 6, it's about 61. And it's fairly linear. So an ACE of 1 is going to be, I think it was 76. ACE of 2 was 73. ACE of 4 was something like 67. All the way down to, yeah, 61. 61. Questions? No? Okay. So it brings, when I decided to do this study, I thought, okay, I want to introduce the study. I think it's very interesting. I think it has a lot to, we have a lot to learn. Maybe it's not all accurate. Maybe some of it is. But I think there are some scientific gaps in our understanding of how trauma affects biology. I don't think we know the full story. So I'll try my best to kind of hit on some important topics without, boring you, but because some of it can be a little bit, I don't want to get into too much of the details, but I think there is a picture emerging that I'd like to share. So, neuroscience, the research has linked childhood maltreatment to long-term changes in brain structure and function. That has been a link. It's been shown. There's Dr. Bruce Perry. He's done a lot of work about this, and he's published a lot. So he has suggested there's problems in the maturation of regulatory areas of the brain, hippocampus, amygdala, the emotional centers. I'm sorry, the regulatory, the frontal cortex, the higher functioning parts of the brain. So there's problems in the maturation of that, and also an overactivity of the emotional centers. So the emotional limbic system, they get kind of really riled up early, and they become maturing quickly, and then it somehow affects the higher part of the brain, and it's not able to regulate those activities. So he has, he's kind of conjectured this leads to a decreased ability to regulate emotions and behaviors, and to an increased risk of psychopathology. Now, it's a big jump. I don't know how big of it is. I mean, I think there's something to be said about that. I think we see it in child psychiatry where there's not a lot of, there might be family problems, having dynamic issues, abuse or whatnot, but we do see dysregulation problems quite a bit, especially in younger kids. I think it manifests sometimes maybe for other reasons, like fetal alcohol syndrome and whatnot, but the childhood environment does play a role. And to what extent that plays a role, I think this is kind of a start in helping us out. We do know that trauma affects the neurohormonal balance in the system. So early stress is associated with the increased fight or flight response. And there's certain key compounds, CRF, that increases the glucocorticoid secretion overall. And the CRF has been implicated in inhibiting serotonin in the brain. So those studies have been done, and as well as increasing catecholamine release in the brain. So what that tells us is that it might play a role in the development of depression and certain anxiety disorders. Now, I think the jury's still out on it. We don't know enough about it, but it's certainly something to think about. There was a study done, also published in JAMA 2000. Findings of increased stress hormones in adult survivors of child abuse were consistent with prior animal studies that showed markedly high levels of CRF, ACTH, and cortisol in traumatized lab subjects. And that was a big study that showed that many years later, these hormones that are involved in the fight or flight response was very high, similar to what they found in lab animals, actually, in previous studies. There's this emerging field, psychoneuroimmunology. Basically, what it's saying is that they're suggesting that traumatic life events can lead to dysregulation of the inflammatory response. Now, if you go back to that slide about cardiovascular disease, 3.6 times rate of cardiac disease with multiple stressors and abuse and neglect. Could it be that there is some problem with inflammatory regulation? And that's certainly a possibility. There is a study done in 2007 that showed prior childhood abuse was shown to be related to high C-reactive protein. I don't know if you guys know much about C-reactive protein, but it's been studied a lot for its role in cardiac disease. And it's a major compound that people are actively investigating. There's one study done in 2005, 62 women with a prior abuse history by their partners 8 to 11 years earlier. They had significant increase in interferon gamma, another cytokine or inflammatory marker. And we do know that these inflammatory proteins have been shown to have etiological role in many chronic illnesses, including, like I talked about, in heart disease. Now, with this A study, there's been a lot more studies, like I'm showing you. And this is a major one, the Canadian Community Health Survey in 2007. They had 36,000 participants. They showed patients with PTSD had higher rates of heart disease, respiratory, chronic pain, and GI. Kind of confirming some of the things we know. They didn't look at adverse experiences. They looked at already diagnosed PTSD. So we do know there's a complex interplay between biology and environment. One of the study leaders was hoping that there would be new avenues of study that will provide insights into various pathways that lead to negative health and social outcomes, and will hopefully lead to more effective methods to prevent and treat the effects of these adverse childhood experiences. Any questions? Yeah.
In the study that determined actual demonstrable changes in brain, I don't know if it was structure or function, probably function.
Mm-hmm.
What were the techniques used to determine that?
So are you talking about, let me look.
One of the studies focused on the
Serotonergic levels?
ACEs and changes in brain function.
Well, this one here,
Yeah.
they didn't study the actual ACEs and development. They didn't study that. But these studies that I'm talking about, Dr. Perry did, he measured the level of arousal in various parts of the brain, depending on whether the person actually had an abuse history or not.
Something like a PET scan.
Like a PET scan, right. And he did a lot of these studies, so you might want to take a look at that. It's pretty interesting. He showed how maybe some parts of the brain were more active than others and how some were less active. And with these scans kind of showed that there is maybe some issue in the level of development of the brain. Again, a lot of this is kind of newer type of research, and I think it's ongoing. People are learning more about. Anything else?
The large study that was done in Canada with 36,000
Right.
folks, so we're talking about middle class as well?
That's a great question, and to be honest with you, I don't know. But that's a really good question. Yeah. Yeah, I don't know that question. I don't know the answer. He was wondering if the study in the Canadian Health Survey was also on middle class participants. And I haven't looked into that study enough to really give you a good answer. I guess the last thing we talked about, hopefully lead to more effective methods to prevent and treat effects of these ACEs. So, again, ACEs are common. They have profound effects 50 years later. The way we can look at it, they're transformed psychosocial experiences, oftentimes negative, right, into organic diseases, social malfunction, and mental illness. And they may be a major determinant of the health and social well-being of the nation. Far-reaching statements, something to think about, kind of stimulate your own interest and maybe discussion. And, you know, Dr. Anda, he said, understanding these broader implications of ACEs is necessary to document their lifetime consequences and to highlight the public health importance of investing in primary prevention programs aimed at reducing them. So that brings us to kind of the next part, the final part of the presentation, which is what do we do about it now that we know that this is a major issue and a major problem. It's probably the hardest part, right? Like, what do we do about it? So obviously they're daunting. These implications are big. It's not like you can just go and, you know, stop child abuse or stop neglect or stop parents from using drugs. You can try, and I think that's what the whole point is. Maybe we have to try a little harder and shift our focus a little bit. They suggest that primary preventions are tied to changes in society that could support and enhance home environments and family life. So we live in a libertarian kind of culture, right? I mean, people don't like CPS knocking on their doors every day. How do you change this? These changes in society. I think there are some ways you might be able to go about doing it. But, you know, we'll talk about that.
Well, I suppose a big program of public information about this.
I think you're right, too. And I think that's what the author suggested, maybe a big push in the media, just like with smoking. A big push in the media, a big push with, you know, different avenues where it can get the word out. They were actually suggesting talking about it in movies and TV shows, that type of thing. I mean, those are big kind of, you know, maybe that'll happen down the road. What do we do initially? So public health responses, interventions addressing these behaviors are likely to be more effective if ACEs are acknowledged and addressed through both prevention and treatment efforts. So, you know, when you're treating a 17-year-old who has started using heroin, I think most of us who are in this line of work, we're very wary that there's probably a lot of negative experiences this kid may have had in their life, and trying to deal with that. Not only the behavior, but the emotional states behind their behavior and how they're dealing with traumatic influences that have happened many years ago or are still occurring. And you know, I think when you talk about substance abuse treatment, I think that's the shift right now. We're going towards more of a trauma-based treatment model in treating kids and adults with addiction. So this has just been in the last, I think, 20 to 30 years, there's been more emphasis on this. So again, what can we do? Dr. Guman, my supervisor, she says she wants to know what she can do, right? Because it's kind of like, well, now what? So you can start by increased screening. That's one thing we can do. So people that come in, maybe we give them a survey, or maybe that needs to be happening in more places, various shelters or community agencies. Maybe people need to be aware that a lot of these kids and teens and adults have been dealing with trauma in their life. It's important to have a high level of suspicion. This is very important. High level of suspicion of additional adverse experiences in individuals with known negative exposures. So you have one, you know that. So you have no excuse of letting the others go. There really isn't. I mean, somebody has been dealt some sort of traumatic event. You really need to have your guard up that there's other issues going on in that family, in that life, based on not only this study but others. So that may lead to earlier and improved treatment. May. Hopefully it does. If you screen a little better, if you screen more vigilantly, you might get kids, and not only kids, but their caregivers. That's important. So I've shifted a little bit in my focus when I'm dealing with this. Sometimes I really am pushing the mom. I'm really pushing the foster parent. They need to get their help. They need to get their treatment. I used to not do that, actually. So it shifted some things, not only with suicide assessment, but, single parent. They're going to be overstressed. There might be things in their life. There might be drugs and alcohol. There might be their own domestic violence. There might be a lot of things. So they need to get in and see their own therapist, psychiatrist, doctor, see how they can improve what they're going through and hopefully help what the kids are going through and the family. So increased education, like you were talking about, right? It needs to take place across numerous professions and social service systems. So getting the word out, awareness, education. Importance of physicians and providers in addressing underlying trauma and adverse experiences in addition to disease. And this is very hard. This is more about, how much time and effort and do primary practice, primary care doctors. I mean, this is one of those things that we need to educate maybe some of the general medicine too, and collaboration with psychiatry and pediatrics, that might help. Importance of the biopsychosocial approach to health. So we do that here in this department, really focus on biological factors, psychological factors, social factors. This can give us a better understanding of if there is trauma and to what extent there is trauma, what the family life is like, getting a more holistic kind of approach as to how to treat this situation rather than, well, okay, let's treat, you're depressed, here's some Zoloft or something. And I guess if there's one thing I learned in the program is don't do that.
Well, you use it as an adjunct, but you don't want to forget the rest of it.
You're right. And I think what I'm trying to say is don't limit it to just that. Which I think actually, unfortunately, reading New York Times articles and stuff like that, it seems like the model is to go towards kind of the 15-minute visit. I mean, some people can do that, I guess. But I guess the approach of especially with child psychiatry, dealing with the family is of utmost importance in what's going on in that, not only the family, but extended family, cousins, relatives, foster parents, this, that. There's a lot of complications. So again, a shift in primary prevention efforts to include programs that aim at treating underlying family systems issues that give rise to ACEs. So examples of these, some specific examples. What can we actually do? Like maybe start a program or something. Targeting teens and young adults prior to having children. Or couples who plan on having children. People who actually want the help. Hey, we want to inform you on what it's like to have kids. Or we want to inform you, do you have your own issues in your family? Do you want to know how to raise your child better? Do you want to know how you improve your own system? We don't do a lot of that, I guess. We see them at the youngest, maybe 3 or 4. A lot of times, maybe too late. I don't know. We can help some. Hopefully, we can help a lot, but maybe it's better to kind of target it earlier. And then programs aimed at parents and caregivers of infants. Now, that's a pretty big deal, because really a lot of damage is being done in very, very young kids that is kind of hidden and not talked about, and just like, hopefully it doesn't happen. Let's just deny it. I don't know. I mean, pediatricians have a big role here because they're the ones seeing these kids at 0 to 3. We don't end up seeing them for the most part. So that's like a big deal, I think, like what happens when you're an infant. That's really like a class of people that really are, in some ways, have no it's hard to, I mean, it's just hard to think about. No real recourse, because they're at the mercy of how they're being treated at home, you know? And maybe we need to target those kids. I mean, we know from the pyramid and everything else, there is this disrupted development and social problems and whatnot that lead lifespan, right, of problems. So can we help those kids at 0 to 3? Kaiser Permanente CDC, they've started a Healthy Steps program that includes experts on psychosocial developmental aspects of childhood. They aim to develop strong relationships with families of children aged 0 to 3 through home and office visits as well as through telephone advice lines. That's a very innovative program. Can we start one in Arizona? I don't know. Should I start one in Arizona? Okay. But I don't know. I think that it's important to keep that in mind. These are big, big issues, and it takes a lot of resource and funding, and people recognizing this is a big problem. Secondary prevention, again, so, you know, teens who have already started using drugs, smoking, other behaviors, they're sexually acting out. So increased recognition of occurrence and understanding of behavioral coping strategies. So understand it in the context of trauma and negative life experiences. So we need to focus on both the behavior, right, and the childhood, you know, basically, you know, experiences that they had growing up. And one of these approaches right now is being looked at a lot is trauma-focused CBT. That's just one modality. There are many more used for trauma these days, but trauma-focused CBT is being used a lot in the juvenile system. It's being used in teen substance abuse groups and whatnot. And there is a push towards not only the CBT part of it, cognitive behavioral therapy, but really having a trauma-focused part to it. So more of the dealing with the psychodynamic consequences and issues of very young life. So psychopharmacological interventions, these kids and adults do need medication, right, like you were mentioning. Sometimes potent medication to help them deal with their symptoms. Also, we need to address lifestyle approaches. So we know that there's likely increased inflammatory reaction in the body. We know there's probably increased stress hormones along with these symptoms. We know that exercise helps with that. You know, advocating for lifestyle changes. Is there a possible role of omega-3 fatty acids in dealing with heightened or increased inflammation? That's a question that some researchers are looking at. Other compounds that may help regulate the stress and inflammatory response, as well as psychotropic compounds, that could be helpful. These are ongoing projects a lot of people are doing. This is my thought. This wasn't really directly talked about in the study, but positive social connections may play a protective factor, decreasing the vulnerability to early life stress. So can group therapy be a role here in helping kids and teens process traumatic events in a safe and sharing environment? Will that help them deal with the issues they grew up with as well as the ongoing behavioral issues? I think that can. I mean, I don't know if it's been studied at length, but I have a feeling that this is probably a big part of it, is connecting with people, not only peers, but adults that care and they can trust. Play therapy. I've been doing a lot of play therapy at the schools recently. I do find that it's helpful for young kids with developmental issues and traumatic histories to vent whatever they're going through in their household. And actually, it seems to be fairly powerful. So we shouldn't minimize, you know, the word play therapy kind of makes it seem like it's fun and games. But I think it can help with very young children. And there's some big names. Dr. Lenore Terr from UCSF has done a lot of research and written a lot about that in traumatic experiences in kids. And then tertiary prevention, like when you look at adults, like many years downstream, it continues to be very challenging. Effects of trauma and chronic illness is often overlooked in traditional medical practices. So many physicians are not equipped to deal with the complex psychosocial aspects of their disease state. So there are complex psychosocial aspects to heart disease, to liver problems, to COPD, diabetes, obesity. They're oftentimes very complex issues, and it's really hard if you're not equipped to deal with it. So basically, ideally, I think we're going to need increased physician awareness as well as greater collaboration like we talked about. The scope of these changes are far-reaching. They require a shift in thinking about what causes long-term chronic medical illness. That's a big statement. Some adults may benefit also from psychotherapeutic interventions. For primary care, it seems like mind-body approaches could be very useful, dealing with decreasing the sympathetic activity and increasing the parasympathetic response. I think it could be very helpful in dealing with these elevated levels of neurohormones and inflammatory markers. And maybe there needs to be a little more, I don't know, maybe some more research on mind-body approaches with traumatized individuals. I think there have been a few. So the end goal is to treat the individual's current medical and psychiatric problems in the context of their unique traumatic experiences. The bottom line is that our current models of treating trauma through the lifespan is limited, and it's currently evolving. Again, like I said in the very beginning, this is the tip of the iceberg, and future treatments will likely be modified through the lifespan to target the most salient aspects of their negative consequences. So throughout the lifespan, people are going to be dealing with different issues at different times, and that's going to be complicated too. Like, what do you work with a 10-year-old versus a 35-year-old, or a 68-year-old versus a 27? They're all going to be a little bit more kind of individualized depending on what they need at that time. Final thoughts: the magnitude of the difficulty of introducing the requisite changes into medical and public health research, education practice can be offset only by the magnitude of the implications that these changes have for improving the health of the nation. And a final thought is that the solution to adult problems tomorrow depends on large measure on how our children grow up today, and I believe that. So thank you for your time. Any questions?
I would bet that in addition to the obviousness of many of these things, the kind of things that might immediately come up when you take the history.